Today, we will discuss about preoperative, intraoperative, and postoperative fetal care. So the first topic is about preoperative care. Preoperative care begins with the decision to perform surgery and continues until the client has reached the operating area. The goal of preoperative care is to prepare the patient physically, psychologically, spiritually, and legally. Preoperative assessment. The first one is review preoperative laboratory and diagnostic studies like complete blood count, blood type and cross-match, serum electrolyte, urinalysis, chest x-ray, electrocardiogram, or other tests related to procedure or client's medical conditions such as protothrombin time, partial probabilistic type, blood urea, nitrogen, creatinine, and other radiographic studies. And then the next one is review the client's health history of present illness and reason for surgery, like past medical history, medical condition acute or chronic, previous hospitalization and surgeries, history of any past problem with anesthesia, and next allergies like and present medication. And for the next one is assess physical needs like ability to communicate, vital sign, level of consciousness, confusion, drowsiness, unresponsiveness, weight and height, ability to move, ambulate, level of exercise. And then the next one is assess psychological needs like emotional state, level of understanding of surgical procedure, preoperative and postoperative instruction, coping strategies, and support system. And for the last one is assess cultural needs like language, need to interpret. The next one is obtaining informed consent. Before surgery, the client must sign a surgical consent form or operative permit. Next one is client must sign a consent form for any procedure that requires anesthesia and has risk of complication. If an adult client is confused, unconsciousness, a family member or guardian must sign the consent form. If the client is younger than 18 years of age, a parent or legal guardian must sign the consent form. In an emergency, the surgeon may have to operate without consent. Healthcare personnel, however, makes every effort to obtain consent by telephone or fax. Each nurse must be familiar with agency policies and state law regarding surgical consent form. Client must sign the consent form before receiving any preoperative sedative. The nurse is responsible for ensuring that all necessary parties have signed the consent form and that it's the client's chart before the clients go to the operating room. And the third one is preoperative teaching. Information in preoperative teaching plan varies with type of surgery and the length of the hospitalization. Teaching clients about their surgical procedure and expectations before and after surgery is the best done during the preoperative period. Clients are more alert and free of pain at this time. For the last slide of preoperative, we have preoperative nursing teaching points. Preoperative medication discussed of the frequency of assessing vital sign and use of monitoring equipment. Explanation and demonstration like deep breathing and coughing exercises, use of incentive spirometry, how to support the incision for breathing exercise and moving, position changes, feet, legs, and exercise. So now, the next topic is intraoperative care. Intraoperative care is patient care during an operation and auxiliary to the operation. Activities such as monitoring the patient vital sign, blood oxygenation levels, fluid therapy, medication, transfusion, anesthesia, radiography, and retrieving samples for laboratory tests are examples of intraoperative care. The purpose of intraoperative care is to care and and to maintain patient safety and comfort during surgical procedures. Some of the goals of intraoperative care include maintaining homeostasis during the procedure, maintaining strict sterile techniques to decrease the chance of cross-infection, ensuring that the patient is secure on the operating table, and taking measures to prevent hematomas from safety strip or from positioning. And now we will tackle physical environment during intraoperative care. We have 6. The first one is surgical suite, unrestricted area, semi-restricted area, restricted area, holding area, and operating room. So the first one is surgical suite. Control environment designed to minimize the spread of infection, allows smooth flow of patient, personnel, and instrument equipment. The next one is unrestricted area, means personnel in street clothes interact with those in scrub, holding, and information area. The next environment is semi-restricted area, means peripheral support areas and corridors with only authorized person or people must wear surgical attire and cover all head and facial hair. The next one is restricted area. We have the operating room, scrub sink areas, and clean corner, and mask required. And then second to the last is holding area, waiting area inside or adjacent to surgical area, final identification and assessment, minor procedure performed, friends, family allowed. And then the last one is operating room. Geographically, environmentally, bacteriologically controlled, restricted in inflow and outflow of personnel, preferred location in next to post-anesthesia care unit. So the next one is surgical team. We have 5. The first one is perioperative nurse, circulating nurse, scrub nurse, surgeon, anesthesia care provider. For perioperative nurse, the responsibilities is to prepare room with team, patient advocate throughout surgical experience, and for circulating nurse, not a scrub, gown, or glove, remains in a sterile field and documentation. For scrub nurse, follow designated scrub procedure, gown and glove in sterile attire, and remain in a sterile field. For surgeon, physician who perform the procedure responsible for preoperative medical history, physical assessment, and patient history. Surgeon assistant can be physician or RN who function in assisting role, hold retractors, assist with hemostasis and suturing, and may perform portions of procedure under direct supervision. And for anesthesia care provider, we have, or the responsibility is administer anesthesia, anesthesiologist or nurse anesthetist, maintenance of psychologic homeostasis throughout intraoperative period. So now we have a classification of anesthesia. We have general anesthesia, local anesthesia, regional anesthesia, and conscious sedation. So what it means? For general anesthesia, means loss of sensation with loss of consciousness, skeletal muscle relaxation, and analgesia. For general anesthesia, IV induction agent, induce pleasant sleep, rapid onset. And for inhalation agent, enter body through alveoli, rapid excretion by ventilation. For local anesthesia, loss of sensation without loss of conscious, topically, intracutaneously, subcutaneously. And for regional anesthesia, loss of sensation in body region without loss of consciousness when a specific nerve or group of nerves in block with administration of local anesthesia. And for the last one is conscious sedation, minimally depressed level of consciousness with maintenance of patient protective airway. airway reflexes. And for nursing management for preoperative care, the first one is before surgery. We need to check the patient before the surgery, like psychosocial assessment, physical assessment, and chart review. The next one is chart review, means we need to check history and PE, urinalysis, CBC, serum electrolyte, chest X-ray, ECG, ultrasound. And the next one is room preparation. Surgical attire worn by all person entering OR suit. Electrical and mechanical equipment check for proper functioning. And basic aseptic techniques. Center of sterile field in surgical incision. Only sterilized item in sterile field. Face shield, cap, gloves, apron, and eyewear. And for the positioning of the patient, accessibility of operative site, administration and monitoring of anesthetic agent, maintenance of airway, correct skeletal alignment. Nursing management, prevent pressure on nerves, skin over bony feminine eyes, provide for adequate thoracic exertion, prevent occlusion of arteries and vein, provide modesty in exposure, recognize and respect needs such as pain or deformities. So the last topic is about post-operative care. The post-operative period begins from the time the patient leaves the operating room and ends with the follow-up visit by the surgeon. The post-operative care is provided by two. The first one is PACU. PACU means Post-Anesthesia Care Unit. It is the unit where the patient are temporarily admitted after any surgical procedure. And then the last one is SICU. SICU means Surgical Intensive Care Unit. It's the multi-specialty medical care center for critically ill patient who require surgery or are recovering from surgery. For post-operative care, we have the purposes. Purposes to enable a successful and faster recovery of the patient post-operatively, to reduce post-operative mortality rate, to reduce the length of hospital stay of the patient, to provide quality care service, to reduce hospital and patient costs during post-operative period. And we have the scope. All patients who undergoing surgery, responsibility and authority by the nurse. For post-operative care unit or post-anesthetic care unit or PACU, patient is still under anesthesia or recovering from anesthesia are placed in the unit for observation by highly skilled nurses, anesthetists, and surgeon. PACU should be soundproof, painted in soft color, isolated, and these features will help the patient to reduce anxiety and promote comfort. Phases of post-op unit. We have two phases. Phase 1, it is immediate recovery phase and requires intensive nursing care to detect early sign of complication. Receive a complete patient record from the operating room which to plan post-operative care. It is designated for care of surgical patient immediately after surgery and patient requiring close monitoring. Phase 2, care of the surgical patient who has been transferred from the phase 1 post-op unit. Patient requiring less observation and less nursing care than phase 1. This phase is also known as a step-down or progressive care unit. Nursing management in post-op unit. To provide care until the patient has recovered from the effect of anesthesia. The first one is assessing the patient. Monitor vital pulse, volume and regularity, depth and nature of respiration. Assessment of patient O2 saturation, skin color. And then the next one is keep monitoring vital sign. Check the level of consciousness, ability to respond to command. Maintain intake and output. maintaining IV stability, assessment of surgical site, can hemorrhage. It is a serious complication of surgery that resulting death. It can occur in immediate post-operative or up to several days after surgery. If left untreated, cardiac output decreases and blood pressure NHP level will fall rapidly. Controlling nausea and vomiting. These are common problems in post-operative period. Medication can be administered as per doctor's order. Example, metoclopramide. And the last one is teaching patient self-care. Expected outcomes, immediate post-operative changes, written instruction like wound care, activity, dietary recommendation, medication and follow-up checkup,